Meeting recorded.
Welcome to CCHP's annual Special Needs Plan Model of Care Provider Training. This is for 2023. So what are objectives? The objectives is to gain an understanding and comprehension of CCHP's Special Needs Plan, or SNP, understanding and comprehension of the elements of the SNP model of care. At the end of the training, you'll be able to describe the best practices for the model and to improve coordination of care and member health outcomes. Training standards are documented in Chapter 42 of the Code of Federal Regulations. CCHP participating providers who routinely see our Medicare SNP or SNP members must receive training on the model of care initially and annually thereafter. Initial training must be completed within 90 days from correct execution date and annually thereafter. Annual training is provided via a live webinar. The attestation statement must be completed within 90 days from the live webinar. What is the SNP model of care? Needs plans are specialized Medicare Advantage plans for beneficiaries with special circumstances, and there are three types of SNPs. One, chronic SNP for members with severe or disabling chronic conditions. Two, institutional SNP for members requiring institutional level of care. And three, dual SNP for members eligible for Medicare and Medi-Cal or Medicaid. The model has a comprehensive plan for delivering integrated care management for special needs members. It is architecture for promoting quality, integrating benefits, coordination of care, and operational processes. Now, CCHP has a SNP or a dual SNP. And remember, this is members with Medicare and Medi-Cal. It's up in San Francisco County. We do not offer it in San Mateo. Enrolled in the D SNP are responsible for $0 for covered medical services. What are the of being a member of a D SNP at CCHP? Well, CCHP offers specific benefit plans for the unique needs of our population. We have walk-in services at member services. We have medication therapy management, disease management services, non-emergency transportation, holistic and complementary health services. We have community partnerships that help our members. We have over-the-counter allowance and a flex card benefit, amongst many other benefits. What does the model of care consist of? It's written documentation that describes the care management process and operations. It's required by the CMS, must be QA accredited, and renewal depends on scoring and ranges from 1 to 3 years. CCHP received a 3-year approval in 2022. There are model of care domains and 15 elements. So the 4 domains are description of the SNP population, which has 2 elements, care coordination, which has 5 elements. Domain B is the provider network, which has 3 elements. And number 4, which is quality measurement and performance improvement, has 5 elements. The reason that CCHP has a SNP model of care is because it responds to our mission to provide high-quality, affordable health care through culturally competent and linguistically appropriate services. CCHP provides services to the frail elderly, high-risk individuals, low-income and low socioeconomic populations, hence the D-SNP, individuals with multiple chronic and acute health problems, individuals at risk of medication and treatment non-compliance, individuals that lack family support, and we provide various other services. The SNP MOC. One of the goals is to improve access to care, improve transition of care to reduce unnecessary emergency room and hospital admissions, improve coordination of care through a single point of contact, which is care coordinator, improve access to preventative health services, improve appropriate utilization of services, improve scores, improve satisfaction with providers and the plan, and to improve health outcomes. So what does a CCHP SNP population look like? Currently, we have 3,378 SNP beneficiaries in San Francisco. 95.4% of the population are Chinese. The age is 25 to 101 years of age. 60.8% of the beneficiaries are between 65 and 80. More women than men, 55% being women and 45% being men. Care coordination. Care coordination facilitates effective use of resources to reduce the overall cost of care with the overall goal of improved health outcomes. Care coordination provides a single point of contact for the member. Care includes registered nurses, social workers, and non-clinical coordinators. That is the team that CCHP has. That collaboratively with the member, the significant others and providers of healthcare to implement a plan of care which meets the individual's needs. So what are care coordination activities? The carers perform an initial assessment to identify individual health needs. They develop a comprehensive individualized care plan or ICP, identify barriers to goals and strategies, provide personalized education for optimal wellness, encourage preventative care, post-discharge planning, reviews and educates on medication regimens to promote adherence, assist members to access community resources, including Medicare and Medicaid benefits, assist caregivers when members are unable to participate, and other activities also. So what is risk assessment? CMS regulates that risk assessment be conducted for each member enrolled in a SNP. The team administers the HRA, or Health Risk Assessment, to all of its SNP members. It's a self-reported survey which includes questions on medical, psychosocial, cognitive, functional, and mental health issues. The initial HRA is sent upon enrollment. Annual assessment is 365 days after last HRA. Tele outreach is conducted if an HRA is not returned within a month of the mailing date. The aid provides the basis for the development of the ICT, or Individualized Care Plan, the ICP. Care coordinators review the HRA and may contact the member for follow-up. This is an example of CCHP's HRA, and you can see there are questions on various domains, and they're both in English and in Chinese. So the development of the individualized care plan. Strict regulation requires an individualized care plan is developed for each member enrolled in the SNP. The responses are used to develop or update the ICP. It's also obtained from claims and labs when HRA response is received. ICP is maintained and stored to assure access by all care providers and professional standards of confidentiality. ICP may include the following: members' healthcare preferences, goals and objectives, interventions and services tailored to the member's unique and individual needs, documentation if time-bound goals met or not met. Evidence-based guidelines such as Interqual are used to develop the ICP. The individual plan follows a specific model for its goals, and it's called the SMART model. The specific, measurable, attainable, relevant, and time-bound SMART goals. ICPs developed to address HRO responses and member preventative care gaps. Members who do not respond to the HRA will receive an IP based in part on claims or encounter data. The IP is documented in the care management tool which CCHP has and which is called ESET, and dated when a member's health status changes or at minimum annually. ICP updates and changes are communicated to the member, care, and providers. This is an example of an ICP. ICPs are communicated via mail, fax, and secure email. Requested to sign and return the ICP through CCHP's Care Coordination Department. So what is a disciplinary care team, or an ICT? An ICT includes the following members: the member or designated representative, the care provider, CCHP's Chief Medical Officer, care coordination manager, coordination nurses, medical social workers, MT pharmacists, and as needed. T is determined by each member's needs. Member participation in the ICT helps to address the member's needs and achieve the plan of care. ICT may provide input and evaluate the member's plan of care. CCHP holds ICT meetings regularly with clinical staff where members' individualized issues are evaluated and managed. Care. Transition occurs when a member moves from one healthcare provider or setting to another. For example, a member was admitted to hospital and discharged to home, acute rehab, or skilled nursing facility. This will be a transition of care. The plan of care is updated in the event of a health status change or care transition. Primary providers are notified when patients undergo a transition of care. Medical staff will assist the members to ensure appropriate follow-up care is arranged after a transition of care. Net providers. The net providers are absolutely essential to good functioning of a SNP model of care. Incorporate relative clinical information in the member's care plan. They transition of care protocols, utilized evidence-based care guidelines, annually review delegated group utilization decisions and member appeals process, revision medication profiles in MDM program, contribute to improve the STAR and HEDIS outcome reporting, help improve CAPS and HOS data collection, and participate in the Quality Improvement Committee quarterly meetings. The role of provider. The provider is an integral part of the care team, as mentioned. Encourage a member to work with CCHP's care coordination team. Provide calls from the member's care coordinator and collaborates with the care coordinator to address individualized needs of the members. Reviews the member's plan of care and sends back the care plan attestation. Are encouraged to participate in the interdisciplinary care team meetings. And providers are required to complete annual MOC training. So how do we effectiveness of the MOC? We standardize measures to monitor performance such as utilization metrics, which include admissions, ER visits, and length of stay. Member experience measures, which includes CAP and HOS surveys. And satisfaction with care coordination, which is also measured through a survey. In summary, CCHP's SNP MOC needs to be your model on managing care for your patients. The MOC supports the mission of CCHP and its business objectives. You are key to improving our members' health outcomes. This is the station. The provider is required to complete the attestation, sign it, and return it to the care coordination department as indicated in the instructions on the attestation form. For needs, that would be the care management department, and provider needs would be provider relations. Here are references. One can read further on this topic. Thanks for attending the annual